Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Arshad Khanani of the Sierra Eye Associates in Reno, Nevada, also an adjunct professor at the University of Nevada, Reno. And we're going to talk today about an interesting new treatment approach for diabetic retinopathy. Arshad, welcome to Retina Synthesis.
Thanks, Carmen. It's a pleasure to be here and excited to share with you the results of the Kallikrein study, the part A of the study.
So the Kallikrein study involved an inhibition of plasma kallikrein pathway, which is a pathway that most retina specialists are not familiar with. We know all about the VEGF pathway. Can you tell us why plasma kallikrein is relevant in diabetic retinopathy?
Absolutely, Carmen. So this pathway is independent of VEGF, and we know as physicians that we have patients who get anti-VEGF agents routinely, even monthly, and they don't show any improvement. So we know that there are other pathways that are active in patients with diabetic macular edema, and plasma kallikrein is one of those pathways. And we have enough preclinical data showing that it's a validated target for edema, inflammation, and prevention of microhemorrhages. And pKal is a key driver, as I said, independent of VEGF in patients with diabetic macular edema. And activation of plasma kallikrein and kinin pathway leads to the release of bradykinin, and that's why you start to see leakage and inflammation. So the goal is, if we can put a stop on this pathway, we may be able to help our patients with diabetic macular edema.
So the study was really focused on eyes that had VEGF treatment but were not doing particularly well. Is that correct?
Yes, that is correct, Carmen. In this study, we actually were looking for suboptimal responders, and the way to look for it is obviously patients who have received aflibercept recently, and if they have not shown improvement in their edema, then we know that they have some other mechanism that is more potent, like pKal. So we included previously treated patients who had not responded very well to aflibercept, and they were enrolled in this trial. And again, we are looking at this molecule here, THR-149, which is a very novel, potent inhibitor of pKal. So the goal was to see in the part A if we can find the right dose, and then after that, the part B will be looking at comparing it to aflibercept.
So a dose escalation trial. How was it designed?
So basically, we had 3 different doses: 0.01 milligram, 0.04 milligrams, and 0.13 milligram. So in the phase 1 dose escalation trial, we saw different results in terms of anatomy and visual acuity. So we wanted to use 3 different doses in the same patient population and see which dose would give us the best BCVA improvement as well as CST stabilization or improvement. So here we had patients who had CST of 320 or greater in microns. We had vision of 73 and 39 letters, and they have to have received or 5 or more anti-VEGF injections. And as I said, aflibercept 3 to 8 weeks prior to screening. And then these patients were randomized to receive one of the 3 doses, and they received once a month dosing for 3 months. And we evaluated the visual acuity and CST every visit, obviously, but we wanted to see what happens a month after the last dose. And then they were followed for 3 additional months. And obviously, we also were looking at safety because we want to make sure we don't have a dose that causes inflammation.
So let's talk about safety to begin with. How was it? Inflammation a problem or not?
No, not at all. There was no serious adverse events. There was no intraocular inflammation, and all AEs that were reported were mild to moderate. So really, there was nothing in there in terms of safety. Obviously, the numbers were small. We had a total, cohort of 20 patients in this trial per protocol. So numbers are still small, but we didn't see anything concerning here.
So what happened to foveal thickness and visual acuity?
I think that's the bottom line. So Carmen, when you look at efficacy, so first thing we're looking obviously at BCVA gains. So at 3 months, so after 3 doses of THR-149 in the high dose 0.13 milligram dose, we had mean BCVA improvement of 6.1 letters. Now, again, these are patients who are previously treated, so we are not expecting too much improvement, but we were surprised to see that we had gains of 6.1 letters. And then at 6 months, so there was no treatment between 3 to 6 months, the same cohort had visual acuity improvement of 4.6 letters. So that's the high dose. The lower 2 doses didn't do as well. So I think just the visual acuity gains confirmed that the higher 0.13 milligram dose is the dose to take to part B. But also when you look at CST, interestingly, obviously these are previously treated patients. If you don't treat them, they're gonna get worse. So we didn't see CST reduction with THR-149, but rather stabilization with the 0.13 milligram dose. So good visual acuity improvement, stabilization of CST. And then we looked at each of the patient in the high dose group to see what are the features that show response to this drug so that we can use those learnings in the part B. And so Reading Center did their own analysis, and we don't have details of what they were really looking for. And they thought that 2 patients should not have been included in the trial, but they included it anyway. So if you exclude those 2 patients with the post-hoc analysis, the visual acuity gains are about 9 letters at 3 months, and they stay. So there's a lot of learning from this part A. Bottom line is that we found out the dose, the 0.13 milligram, which can help these patients get more vision.
So does PKL cause intraretinal edema and subretinal edema?
Yeah, so it's really indicated in inflammation and leakage. So absolutely, you are looking at leakage. Now the question is, how much we are stopping leakage with this molecule, and what is the reason we are getting visual acuity improvement? I mean, those are the things we need to further analyze. But the interesting part is that this is a patient population that's tough to treat, and if we can help them gain vision, I think this treatment could be a secondary treatment or an add-on treatment to anti-VEGF agents. And that's why in part B, Carmen, we are comparing it head-to-head with aflibercept in the same patient population that's suboptimal responder to see if THR-149 can have same or better efficacy compared to aflibercept.
What would that study look like?
So in that study, we have about 104 or so patients, and basically patients will be randomized now to the dose, the 0.13 milligram dose that has been chosen based on part A, and then patients will receive monthly injection of either THR-149 or aflibercept × 3, and then we'll evaluate them a month after their last injection to see if the BCVA gains and OCT improvement or stabilization is better, worse, or similar to aflibercept. Now, again, this is a patient population that has been treated with aflibercept in the past, and to see if they continue to not respond or with 3 monthly injection, they get better. So we'll find out those answers. And of course, looking at safety of this in a larger population would be the key.
Is that study enrolling now?
Yes, the study is currently enrolling, and the first patient in the part B has already been dosed.
Well, this is exciting. We've been looking at alternative treatment approaches, and so far it's just been anti-VEGF or steroids. So this is a welcome.
Yeah, absolutely, Carmen. The bar is very high, right? Where you're going against the standard of care, which is anti-VEGF agents. Obviously, with the approval of faricimab, the first bispecific antibody, you're adding on MOAs. But yeah, by itself, without VEGF inhibition, this is one of the very few trials that are ongoing at the phase 2 stage to see if we can help our patients with diabetic macular edema.
So Arshad, thanks so much for participating on retinal synthesis, and we'll stay tuned for more results on PKL inhibition. Thank you.
Thanks, Carmen. It's a pleasure to be here, and I hope to see you soon.